we're good to go.
Good afternoon, everybody. Sorry for the few-minute delay. We had a little technical issue. On behalf of my co-host, Dr. Julie Grapsa, who's the editor-in-chief of JACC Case Reports, I'd like to welcome you to our approximately quarterly ACC Imaging Council and JACC Case Reports Journal Club. I'm Lawrence Rudsky from the Israeli Heart Center, Jewish General Hospital, McGill University, Montreal. And today we have a really interesting topic of acute afterload mismatch after percutaneous tricuspid valve intervention. Today we have the authors as well of the case report, Dr. Geraldine Pham, Dr. Geraldine Ong, Neil Pham, two of the trainees involved in the case, Anas Merdad, who's an interventional echo fellow, and Dr. Daniel Hagmeyer, who's an interventional fellow, and they come from the Division of Cardiology, the structural program at St. Michael's Hospital in Toronto. Julia?
And I would like to welcome, thank you, Lawrence. I would like to welcome our panelists for today, starting from Dr. Rebecca Hahn, Professor of Medicine at Columbia University, a luminary in the field of interventional echo, Dr. Karima Adisia, an Associate Professor of Medicine at University of Chicago, and a multimodality imager with expertise in the right heart, and Dr. Maurizio Ceramasso, Director of the Structural Heart Program at the Cardiac Center His London in Zurich in Switzerland. So, Lawrence, back to you.
Thanks. And now, as I said, we have Anas and Daniel who are going to lead us off with the case presentation.
Perfect. We're going to just share our slides real quick. Okay, so thank you very much for the very kind introduction and for the opportunity to present this case today. I'm presenting this case of acute afterload mismatch after transcatheter tricuspid valve edge-to-edge repair on behalf of the structural heart team at St. Michael's Hospital in Toronto, together with my friend and colleague, Dr. Anas Merdad. My name is Daniel Hagmeyer. I'm also part of the heart team at St. Michael's Hospital. I have no relevant disclosures. So the patient we would like to discuss with you is an 84-year-old lady with a history of hypertension, dyslipidemia, chronic kidney disease, heart failure with preserved ejection fraction. She has no known coronary artery disease. She has some atrial fibrillation. She has no pacemaker. She presented at our clinic with class 3 heart failure symptoms. On physical exam, she was clinically volume overloaded, and she was on effective dosing of medical therapy, which was kind of limited by symptomatic hypotension. Looking at her baseline echocardiogram, as you can see here on the apical 4 chamber view, she has a preserved RV function and a visually mildly impaired RV function. Even so, the standard parameters indicated that she has a normal RV function. Having a closer look at the tricuspid valve, here in this transesophageal echocardiogram, showed a severe tricuspid regurgitation coming from the anteroseptal commissure and extending centrally. Of note is a coaptation gap of 6 millimeters between the leaflets. We then performed a coronary angiogram, excluded coronary artery disease. She had a slightly elevated left anti-diastolic pressure of 18 millimeter of mercury. Her wedge pressure was 21. PA mean was 31. RA pressure was elevated as well with 10, with VVAFs up to 20. Her PVR was 3.8. We then had our interdisciplinary heart team discussion. And in summary, we have a symptomatic 84-year-old, kind of frail patient with severe tricuspid regurgitation despite maximally tolerated medical therapy. So we decided to go forward with tricuspid valve edge-to-edge repair. As you all know, there are overall 4 clips available, and taking in consideration the leaflet lengths, the gap, and the width of the jet, we decided to go with a XTW, which is a wide and long clip. In the procedure, we were able to successfully implant a clip into the anteroseptal commissure, and the result was very excellent, with only trace tricuspid regurgitation left.
All right, thank you so much, Daniel. So almost immediately after grasping those leaflets, the blood pressure dropped from about 125 over 75 millimeters of mercury to around 80 to over 55 millimeters of mercury. And we considered a wide differential at the moment, and including an acute occult bleeding, a pericardial tamponade, acute RV failure, arrhythmia, acute coronary syndrome or LV dysfunction, or a pulmonary embolus. However, we didn't see any evidence of an effusion on echo. There was no new regional wall motion abnormality or LV dysfunction or any ST changes that we were able to see. No arrhythmia, no evidence of a catastrophic bleed, and no change in the anesthetic or vasopressor regimen prior to that event. This is the RA tracing, and you can see on the left side before the procedure, we had a mean RA pressure of about 14 with V waves going up to 20. And on the right side, after grasping the leaflets, the V waves are gone, and we have a mean RA pressure of about 13, which is still a bit elevated, which goes against a catastrophic bleed. Here is a echocardiographic assessment of the RV, and on the left, you'll see the baseline assessment, and you can see that the RV function is reasonable. And on the right side, after grasping those leaflets, you can appreciate the significant reduction in RV systolic function, and you can appreciate also the smoke at the right atrium. This is a strain assessment of the RV, and you can appreciate again baseline assessment on the left side. There was a mildly reduced longitudinal strain. In the free wall longitudinal strain, it was minus 15.3%. And on the right side, there was a significant drop to minus 6.4%. This is the right atrium showing significant smoke and sludge in the right atrium, again, almost immediately after grasping those leaflets. We supported the patients for a few minutes with IV fluids and phenylephrine, and her blood pressure eventually recovered within a few minutes. The patient remained normotensive and eventually left the cath lab and remained also stable on the ward, and clinically has improved and was eventually discharged home the next day. At 1 month in clinic follow-up, the patient has improved significantly. She was enjoying an NYHA class 1 functional capacity, and follow-up transthoracic echocardiographic assessment demonstrated trace tricuspid regurgitation and only mild RV dysfunction. This is her discharge echocardiographic images, and you can appreciate a well-seated tricuspid clip with only trace tricuspid regurgitation. The mean gradient across the valve was about 1.8 millimeters of mercury, and overall the RV function was felt to be moderately reduced. So some important take-home messages that we felt are important for this case is to consider the impact of transcatheter tricuspid valve repair on RV afterload and function when sudden changes in hemodynamics are observed, and to consider a differential diagnosis of hypotension during transcatheter tricuspid valve repair, and be prepared to provide timely support for RV dysfunction. Thank you very much, and we're happy to answer any questions.
So let me thank you very much for the presentation. Lawrence, if I'm not mistaken, we're going to hear of Dr. Ong with a presentation on echo assessment. Great. Geraldine, thank you.
I'm going to share my screen. So for this patient, here are my disclosures. For this patient, we decided to use the edge-to-edge technique to treat this patient's tricuspid regurgitation. With this technique, the objective is to restore the coaptation between the leaflets. So it's a promising treatment that improves the hemodynamics of the heart function, the RV remodeling, and improve heart failure function. And what's the most important thing to know for this technique is that we have to have a very deep understanding of each patient's tricuspid valve's anatomy, and to plan the procedure successfully by knowing which leaflets are involved in the mechanism of the tricuspid regurgitation, the location of the TR jet, and how we can, during the procedure, have good visualization of the leaflets for grasping them. So for this technique, we rely heavily on echo to look at the anatomy. So we use different views during and before the procedure to plan out the procedure. So we often rely on the transgastric view, where we can identify the leaflet anatomy and the region of where the TR jet originates from. We're also going to use modified view or different techniques in the esophageal area to better look at the leaflets. Here, an example: this patient has a mechanical mitral valve, and the leaflets of the tricuspid valve are shadowed. By pushing the probe a little deeper, we are able to visualize the leaflet and make the procedure possible. We're also going to use multiplanar views to map out the valve's anatomy, the origin of the leaflet, and also look at the grasping view to plan of where exactly we're going to position the clip. So by moving the cursor all the way from the left side of the valve, where we can image the septal and posterior leaflet, we can move it further to the center of the valve and image the septal and anterior leaflet, and move it all the way to the right side of the screen, where we can visualize the septal and anterior commissure, which is the location where we most often put clips. So we also use prior and during the procedure, the multiplanar reconstruction views, where we can all at once see the imaging of the valve of all these different dimensions. So this procedure is guided by echo and will image all the different steps. So the first step of the procedure is to navigate the clip delivery system into the heart through the IVC. We will then evaluate the clip location and its perpendicularity to the anatomy of the valve using multiplanar views and 3D views. We will then confirm the grasping of the leaflets using, again, these different imaging techniques, and confirm the grasping on the transgastric view. You see here the clip is located at the anterior and septal commissure. And finally, we'll assess the final result, making sure the leaflets are well grasped, and assess the residual color and look for complications such as RV dysfunction or tamponade. So it's very important or crucial to understand the tricuspid valve's anatomy and TR mechanism, and using these different imaging techniques before and during the procedure makes an edge-to-edge repair successful. Thank you.
Thanks, Geraldine. So what made this case a little bit different was that you had a great result, but the RV became suddenly dysfunctional. So we know that the RV doesn't work in isolation. So we're now going to have Dr. Becky Hahn give us a presentation on the RV-PA coupling and the interactions that are so important that we're beginning to understand more.
Great. Thanks really for inviting me to this really fascinating case discussion. I think I'm still left wondering a little bit what happened, but we'll try and cover some of the possible issues. These are my disclosures. Can you see my slides? Okay. So to understand the RV, I think you have to understand, and to understand the RV in relation to the tricuspid, you have to understand really the RV-LV relationship. And the RV contracts by three separate mechanisms. It's got movement of the free wall toward the septum, which is called the bellows effect. So the septum is your kind of hard surface, and then it's contracting against it. And that's, to me, the circumferential fibers, which are the outer fibers of the RV, and happen to be kind of the secondary function of that the RV relies on. Then there's traction of the free wall, which is performed by the attachment of the RV to the LV. And so when the LV contracts, and obviously we know that it rotates and it's wringing itself out, then the RV does the same and has this kind of peristaltic motion in part related to the LV. So anything affecting the LV is going to affect the RV. And then the primary way that it has of ejecting stroke volume initially is going to be longitudinal fibers. So these are the main fibers of the RV. The RV only has two layers, the longitudinal on the inside, circumferential on the outside. And so the main shortening, the main ejection is due to the longitudinal shortening. And that's why TAPSE becomes so powerful a predictor of outcomes and has been correlated with invasive measures of RV-PA coupling. I think the most important thing to remember is that, one, the RV uses 25% of the work of the LV, but it has to move the same volume of blood, right? So you have a QPQS of 1, you have the same stroke volume across the LV as you have of the RV, but the RV has to do it against a closed mitral valve. So the mitral valve is closed, we're assuming no mitral regurgitation, and therefore all of the stroke volume must be contained within the pulmonary circulation and the left atrium. And this is why we know that anything at all that increases left-sided pressures or pulmonary pressures are going to affect the right heart. And that's why the RV is so afterload dependent. It really has to have very high pulmonary and left atrial capacitance in order to perform optimally. And it's long been known to be more sensitive to acute increases in afterload. We've all, echocardiographers all know about the McConnell sign. You just blow out the mid RV while maintaining typically apical and basal wall motion. And that's very common with pulmonary hypertension of other etiologies as well. And experimental models have actually shown that the pressure load is less well tolerated than volume overload. And this we know now from tricuspid regurgitation, since all of these patients present to us extraordinarily late. And then the changes that occur during the course of increased afterload is that the RV function starts to lose. One becomes dilated out the lateral wall and then starts to lose its longitudinal function. And then what maintains the cardiac output is going to be its circumferential function. And we've known for some time, and this is the initial study, and Neil and Geraldine were both on this, that we looked at the transcatheter tricuspid valve replacement with one of the newest devices and showed that this is the images that you see are from a different device, but the paper is indeed from one of these initial transcatheter tricuspid valve replacement devices, clearly showing that there's an acute reduction in right ventricular function. And so we've known that for some time that would happen. And we take some of the graphs that you'll see now coming up are from my fellow Mickey Brenner, and we are using a PV loop a simulator called Harvey, Harvi, and Harvey is available online, and you can just throw in numbers and it starts to give you the PV loops. And so on the right side, we know that the RV adapts to an increase in the vascular load by increasing its contractility. And so that's why it looked as though strain imaging was okay. So it was a -15 to begin with. -15 in the tricuspid regurgitation patients that we see is not good at all. We usually see RV strains of 25 to 30. Those are the ones that are going to do super well because they've now actually increased and enhanced their longitudinal shortening in order to maintain forward flow. So they've got super RV stroke volume because a lot of it's going backwards. And then what happens is that over time, or with some pulmonary hypertension, and that could be pre or post capillary pulmonary hypertension, you then increase wall stress and you begin to see that the RV starts to fail. And it'll lose first its longitudinal function and eventually will lose its circumferential function. So you saw the study, the case that they showed, it had lost both longitudinal, which was your strain imaging, went down to -6, but it had also lost its circumferential shortening. And that's going to really make the stroke volume and forward flow extraordinarily bad. And so when we look at measures of RVPA coupling, because we do believe that RVPA coupling will be one of the strongest measures that we have to assess true RV function in relationship to pulmonary hypertension, is typically done by invasive means, as you can see in the first two columns. So RV contractile function is end systolic elastance, and then afterload is effective arterial elastance. But we can look at RVPA coupling non-invasively by just having any measure of RV contractility, so free wall strain, global longitudinal strain, fractional area change, or TAPSE, and divide it by the estimate of the RV systolic pressure, whether or not you have torrential TR or not. And multiple studies, we really don't have time to show you all the studies, have actually shown that there are outcomes related to RVPA coupling either in native tricuspid regurgitation as well as post transcatheter device therapy. And what we've learned from Harvey is that when you have an increase in TR, you increase total stroke volume of the RV because it's got to maintain its forward flow. When you have an increase in TR, you're actually decreasing afterload. So obviously now when you think about reversing that process, then what Harvey would say is that you'll see a total RV stroke volume go down and the afterload will go up. But the total stroke work may be roughly the same. As you can see here, that's the area of these PV loops. And the LV stroke volume on the right-hand side goes up. So that even though your total RV stroke volume is going down because you don't have any regurgitation, your RV afterload has gone up. Your forward stroke volume should go up if we're reducing tricuspid regurgitation in the right patients. And this has already been shown by Philip Lurtz's group, and this is a study by Rama looking at a fraction of their patients with CMR and showing indeed that when TR is reduced, that they didn't find a terribly increased afterload, but what they did find was that the RV stroke volume decreased. But in concomitant with that decrease in RV stroke volume was an increase in forward flow. And that's indeed what Harvey would predict, that you would actually decrease RV stroke volume and increase flow. And what's also been shown is that this study by Orban, but also another one out of Philip Lurtz's lab, is that if you look at RV ejection fraction, and that's going to be really the circumferential shortening of the RV, that you can have outcomes associated, pretty powerful outcomes associated with RV ejection fraction. Now, we've also seen it with RV TAPSE as well. But just remember that we believe that TAPSE is longitudinal function will go first, and that the circumferential shortening will compensate until it can't compensate. And I think that the case by Dr. Ong and Dr. Pham failed to compensate their circumferential shortening for whatever reason. And that in addition, what we've shown from the TriValve registry, and Maurizio's on, and this was published just a month or so ago, a couple months, is that RVPA coupling using TAPSE PASP was also predictive of outcomes. That if you had RVPA coupling of under 0.41, that those patients overall had worse outcomes after their TTVI, and it's almost all of those patients had a clip. But in addition, the most interesting part is that if you were able to reduce your TAPSE PASP, reduce RVPA coupling after the procedure versus no change, you had a better outcome. And that really goes to, so this is the change. If you had a change and a reduction, you had a better outcome. And that goes to the concept of RV reserve. And so if you don't have RV reserve, then those are patients that may actually fail. And so when we look at this particular, I'm just going to mention the pulmonary artery pulsatility index, but I think maybe Lawrence should discuss that perhaps later. But my take on this case is that the patient really didn't have normal function. Even though it was read as mild, all those other numbers were normal except for strain, which was already moderately reduced. And in that setting, if you did a rough calculation of PVR, it was also high, so that's not good. The pulmonary artery pulsatility index was very low, also not good. The only thing going for it was the TAPSE over PASP, and that made me think that this patient was going to recover. So without knowing the end, that would have been my prediction, is that there was an acute reduction with failure of compensation, but that over time, that ventricle then compensated plus additional fluids. Obviously, the patient might have been dry, and perhaps that's indeed what's telling the story. Thanks for your attention.
Thank you very much, Becky. That was a fascinating presentation and a lot of space for discussion here. It's a very interesting topic. I would like to move to Karima. Karima, you will speak about the CMR and the risk of probability and also the remodeling. So risk prediction and remodeling in tricuspid regurgitation.
So hello, everybody. So it is my pleasure to talk to you about cardiovascular magnetic resonance imaging and remodeling in tricuspid regurgitation. Next slide. So I would like to begin by going over how we assess the right ventricle on MRI, because there are various views which you can see the right ventricle on MRI that cannot really be seen on echo. So if you look on the left-sided panel, you can see the four-chamber view that we all recognize. Here's in the axial plane. You can make a cut across the right ventricle and in the long axis plane and come up with the inflow-outflow view, which you can see on the far left side. If you have the inflow-outflow view, you can then cut a plane across the pulmonary valve and the apex of the trabeculated RV and come up with the RV outflow tract. So really with MRI, it is possible to look at the RV in any cut plane that you wish to. You can similarly look at the tricuspid valve as well. And you can see the figure does show how you can assess the different leaflets of the tricuspid valve. The problem with MRI is that the leaflets are very thin for the tricuspid valve, and sometimes it's very difficult to see fast-moving structures on MRI. Now, if you look to the far right, you can see on the top row there, this is a patient with pulmonary arterial hypertension, and on the bottom row, a patient with a normal looking RV, and you can already appreciate the changes in RV remodeling in pulmonary arterial hypertension. You can see that the apex of the RV overtakes the LV. You can see the remodeling of the RV body and the tethering of the leaflets. Next slide. So how do we assess tricuspid regurgitation on MRI? Well, we use regurgitant volume and regurgitant fraction. And as we all know, regurgitant volume is the RV stroke volume minus the forward flow through the pulmonary artery. And to calculate regurgitant or stroke volume of the RV on MRI, we use the method of discs. So each of these short axis slices that you see here are obtained at levels along the RV in the long axis plane. And we trace each one of these short axis slices. Each one has a specific thickness, and then use the method of disc to calculate end diastolic volume and systolic volume of the RV. And from that, you can obtain stroke volume. To obtain the stroke volume across the PA, we use what is called velocity encoded imaging. And you can see here that you obtain both magnitude imaging and a phase map. With the phase map actually has within the sequence a calculation of all the velocities and the various pixels going through the main PA. So using that information, you can obtain a graph of flow over time, as you can see in the bottom there in green, and then use that to calculate your forward stroke volume across the PA. Now on the far right side, I just have an example of a patient with severe tricuspid regurgitation. What you appreciate here is that sometimes on MRI, you can tell visually whether the tricuspid regurgitation is moderate or more, because there is kind of an aliasing that happens on the short axis view. Next slide. So when we talk about remodeling in functional tricuspid regurgitation, we can divide it into tricuspid regurgitation with pulmonary hypertension and tricuspid regurgitation without pulmonary hypertension. So, and next slide, or you can see that patients with tricuspid regurgitation and pulmonary hypertension tend to be younger. They tend to have moderate or more pulmonary hypertension. The annulus is not so large, but there is a lot often of tethering. And the RV takes on an elliptical type of shape with papillary muscle displacement due to the RV remodeling. Next slide. In tricuspid regurgitation without pulmonary hypertension, the typical phenotype is often older, often female. These people have atrial fibrillation typically, very large tricuspid annuluses, large right atriums, less so tricuspid leaflet tethering, and a large RV base. So if you look at the RV in those patients with tricuspid regurgitation without pulmonary hypertension, compare that to the tricuspid regurgitation with pulmonary hypertension, you can see that there is more conical remodeling in that without pulmonary hypertension and more elliptical remodeling in the RV with pulmonary hypertension. Next slide. So tricuspid regurgitation with pulmonary hypertension is also called ventricular functional tricuspid regurgitation. And tricuspid regurgitation without pulmonary hypertension has been referred to as atrial functional tricuspid regurgitation. So I think we just click through the various information here, and you can see ventricular functional TR, typically remodeling of the RV, displacement of the papillary muscles, tenting, tethering of the leaflets, and that's how you get tricuspid regurgitation. Whereas in atrial functional TR, big atria, right atrial remodeling, annular dilation, diminished leaflet coaptation, and tricuspid regurgitation. So click a little more. So you can see that right atrial remodeling can be caused by atrial fibrillation, increased right atrial pressures can do it, worsening of tricuspid regurgitation can do it as well. RV remodeling typically happens with left valve disease, increased PA pressures, and also RV dilation and myopathy can cause that. Next slide. And next slide. So this is, I just wanted to show you a couple of studies that help you appreciate this remodeling of the right ventricle in tricuspid regurgitation. So this is an example of reverse remodeling after TR correction. This was a study with 31 patients who had severe functional tricuspid regurgitation post mitral valve surgery. And you can see on the top row, which was 1 month before surgery, and on the bottom row, the images are from post-op, approximately 27 months after surgery. And you can see that the RV looks a little conical in shape, and there might also be leaflet tethering here too, and the right atrium looks big. So there's probably a combination of ventricular functional tricuspid regurgitation and atrial functional tricuspid regurgitation in this patient. And if we look at the graph towards the left, you can see that pre-op RV volumes were pretty large, and post-op RV volumes and diastolic and end-systolic volumes decreased. Interestingly also, the LV volumes increased post-op at 27 months. Next slide. This case also shows you reverse remodeling after in patients with pulmonary hypertension due to CTEPH. These patients all had pulmonary endarterectomy, and you can see that the authors used custom software to assess the leaflet area, coaptation height, tenting volume, and annular area, and compared to a set of controls, which is in green on the graph. So you can see here that pre-endarterectomy patients in the dark blue, and post-endarterectomy patients after 12 months in the lighter blue. You can see leaflet area decreases, post-op tenting height decreases, tenting volume decreases, and coaptation height increases. And I think because of time, I'll end there. Next slide.
Thanks, Karima. That was really informative. Our last talk before we go to the question and answer is going to be from Maurizio, who's going to be talking about the interventional surgical approach to tricuspid regurgitation.
Thanks a lot, Lawrence. Thanks a lot, everybody, for the kind invitation. I share my screen, and I'm gonna give you, for the next few minutes, a quick overview on the interventional or surgical therapeutic possibility that we have to fix the tricuspid regurgitation. These are my disclosure. And as Karima said, whenever we talk about tricuspid regurgitation, most of the time we refer to functional etiology, whatever is ventricularly driven tricuspid regurgitation or atrially driven tricuspid regurgitation. Most of the time, when we talk about isolated tricuspid regurgitation, we refer to functional etiology. Obviously, there are also organic or iatrogenic etiology, there are endocarditis etiology, but most of the time, and we will focus on this entity, we talk about functional TR. Whatever is the initial reason, so atrial enlargement, ventricular enlargement with the pulmonary hypertension, obviously there are some differences as we have been seeing, but we can say that functional TR is a progressive disease with at the beginning of the disease, mainly the annulus is dilated with minimal or mild alterated RV remodeling. And then the more the process is ongoing, the more the RV remodeling progress. And we move from an early stage, we like to divide in these 5 stages according to the anatomy, the TR, the more we will have larger gap, leaflet tethering, RV remodeling. And actually, the type of treatment that we use in both surgery and in intervention, structural intervention, is highly depending on the stage of the disease. Let's say that the more the RV is remodeled, the less just fix the annulus is gonna work. Let's say that most of the time, the surgical strategy used for functional TR is to fix the annulus. So we use something which is working in the early stage of the disease, sometimes also in the, let's say, more late stage of the disease. But ring annuloplasty, sutural annuloplasty have been almost abandoned in isolated TR treatment. But ring annuloplasty, so putting a ring prosthesis and annuloplasty, is the most used technique so far. And then, but this is quite performed rarely. Something on top of annuloplasty has to be added if there is also remodeling of the ventricle, like edge-to-edge or leaflet augmentation, and in some cases, end-stage also replacement. But still, there are not that many data on this adjunctive surgical act on the tricuspid. Despite a lot of improvement in surgical technique by using disease-dedicated shape of annuloplasty, so 3D shaped annuloplasty with incomplete shape, so dedicated to the tricuspid, despite the fact that most of the isolated surgery can be performed on a beating heart with minimally invasive approach. So a lot have been done to reduce the invasiveness of isolated tricuspid surgery. Despite this, over the last year, the mortality remained high, ranging between 5 to 15%. But overall, let's say that on average, isolated tricuspid regurgitation is carried out with about 10% mortality, and this is stable over the year despite all this improvement. And the reason is this one, that we get patients and we operate patients still too late. Too late means that the RV is failing. There is probably severe pulmonary hypertension. Basically, we have no RV reserve. And this is true for both surgery and interventionally. But obviously, the impact of surgery in a right ventricle without reserve is much more impressive than an impact of a structural intervention. So the message is that in order to reduce this together with improving the technique, we should probably improve also the indication and the timing. We should treat patients before RV failure is occurring. For patients which are at high risk, which are still the vast majority, in the last guideline, in the last European guideline, for the first time, transcatheter repair have been mentioned, even if with only 2B level of evidence due to lack of data. But this is the first time that in a valvular guideline, this appears. And we have 3 devices in Europe commercially available for tricuspid repair. One is TriClip that you have seen in the case just presented. Then we have another edge-to-edge device, which is the Pascal. And then we have an annuloplasty device, which is the Cardioband. We have seen already the TriClip. There is now the 4th generation TriClip available with different sizes, with the possibility to capture the leaflet independently. It works pretty well if proper patient selection is performed with sustained reduction of TR. So if we achieve acute TR reduction, this is stable up to 2 years. And most importantly, the safety profile of this therapy is extremely high. So even if the patients are at high risk, we can accomplish good result with low morbidity and mortality. This is true also for the Pascal. The Pascal is a slightly different device which perform a similar concept, so approximation of the free edge, so transcatheter edge to edge of the tricuspid. There are 2 different devices. One is wider and another one is more narrow. The results are pretty much similar to the one obtained by TriClip, even if there are much less implants in Europe so far, but the number are increasing. We can achieve TR reduction with extremely high safety profile. Few words regarding Cardioband, which is annuloplasty. It's really appealing because we don't touch the leaflet, so we do not preclude anything for further replacement or further leaflet repair. It is delivered through the femoral vein, and then the band is implanted from the anteroseptal to the posteroseptal commissure by means of different anchors. And then after the implant, the band can be cinched. And especially if there is a central gap, the cinching of the band increases the coaptation of the leaflet at the level of the center of the valve. But let's say that this therapy is technically quite demanding. It needs advanced skill, and so the diffusion and the penetration is still quite low. The safety profile is good, even if it is not as good as for leaflet therapy, mainly due to some issue with the right coronary artery that have been described in the CMARC trial. But sustained TR reduction can be obtained. And then last but not least, not all the valves can be repaired. This is just an example where there is a huge gap. There are 2 leads through the tricuspid leaflet. Obviously, we cannot think to repair this valve. We can consider whether it makes sense to do anything at all, but this is a valve that you should consider to be replaced. There are different devices to replace the valve, orthotopic or heterotopic. The one that collected so far the highest number of implants is the Evoque from Edwards, which is an orthotopic device delivered through the femoral access. Obviously, we can abolish TR if we replace the valve, but we have to acknowledge that the safety profile of replacement, for some of the reasons that Becky already mentioned, but also for some other reasons like the profile of the catheter, is not as good as for the repair. So I think in the future there will be spaces for both. There will be complementary rather than competitive therapy. But again, patient selection will play a major role, and we still have to learn a lot on how to select patients for this kind of therapy. Thank you for the attention.
Thanks, Maurizio. That was really great. it's a constantly changing world in terms of, particularly on the right side, on the tricuspid side. We're going to go first to a question from the audience, which is from Malak Merdad, who I'm going to rephrase his question. Or is there is there a role to prepare the patient for the tricuspid intervention by aggressively diuresing without getting into the problem of renal failure, or preparing them with milrinone to try and potentially shrink down the RV size, the preload, in order to increase the chances of successful procedure? That's really addressed to anybody who wants to hop in, who wants to jump in.
Well, I can take that on. We commonly do this, particularly for edge-to-edge or replacement procedures, where we try and reduce the coaptation gap in the annular diameter. But as we saw in this case, if you decrease preload and then suddenly increase afterload, and the RV is marginal, then you do have to have inotropes ready, such as milrinone or dobutamine. But the number of times that's actually required is quite few. Even with replacement, as Becky alluded to, where the risk for that seems much higher, it's not common that the patient needs to have that degree of support. But there are two phases of afterload mismatch, at least that we've observed. One is acute, which is more severe, and the other is somewhat delayed after about 48 hours, and then they just go into a bit of a low output state, and then they just need inotropy and avoidance of excessive diuresis to maintain the preload.
Any other comments?
Yeah, I mean, I think we're still trying to figure out, who those patients are and how to walk that fine line. And I think one of the things I didn't mention is right atrial compliance. And in those patients that have very chronic atrial fibrillation, these massive atria, you just can't even believe how big they are. They just have no atrial compliance and, aren't going to contract or anything. And they may need more preload. But we're still trying to fine tune who those patients are that we can diurese at will, and those that may need to have some preload in order to make it out of the operating room.
Thanks. I guess related to that is another question from the audience, which says the substantial reduction in TR severity in this case, and this is what you discussed also on our previous call, Becky, from severe to trace is quite impressive. Can we attribute the severe worsening in RV function post-clip to the degree of reduction in TR severity, losing the pop-off function? And should we aim for imperfection?
I mean, that is a really good question, but it is indeed what we showed in the tri-valve registry. So the reduction in RVPA coupling was directly related to the amount of TR reduction. So the more TR reduction, the greater the reduction in TAPSE over PASP. And remember, it's typically both a reduction in TAPSE and an increase in PASP. So I do believe indeed that it's related to the amount. And Neil, you had commented on that at one point also, that, I mean, you took the TR to nothing as if it were a replacement device.
Yeah, that's the unusual aspect of this case. One of the advantages of TR is that it is imperfect, and we usually don't get them to trace. We can get them to mild and moderate often. But its weakness can also be its strength in some of these patients who've got a lot of RV dysfunction and remodeling and some degree of pulmonary hypertension.
So, thank you very much. So going back, actually, a question to the authors is, we saw that the right ventricular systolic pressure was 48. You showed us PVR 3.8. So as Becky described that, it was more than mildly impaired function. Do you think, in retrospect, that you could have had another transcatheter option, or you would still, if it was turn back time, you would do exactly the same?
So maybe Geraldine can answer that one, because we struggle with this question all the time. I think you're on mute.
Yeah, we do struggle with this all the time. I guess just in clinic yesterday, we had this very same dilemma. I guess that one of looking at the options, repairing, edge repair versus replacement, is that in our opinion, or it has been more difficult to predict as for the result or the reduction in TR using edge-to-edge repair as opposed to replacement. So that is also, that increases the unpredictability of the case. So going backwards, I don't think we would have changed, we wouldn't have favored a replacement over a clip in this patient. But I guess at this point, we still don't know who would benefit more from either techniques, depending on their anatomy, of course.
It's just Maurizio showed that the safety with replacement is probably not quite as good as edge to edge. You know, after TR, patients go home the next day, just as this patient did. Patient is elderly and frail, and you want to do no harm. We don't usually get the TR to trace, so that's why the case was interesting that she developed this afterload mismatch, but most patients don't develop this. But we don't know in a few years what we're going to be doing, whether it's going to be one or the other, but it's probably a bit of both so that we have a toolbox.
Thanks. I remember going back a few years when I used to go to meetings when we could travel. I remember running into Becky at an ESC meeting, and she said, if you want to see acute RV dysfunction, just close off, put a percutaneous tricuspid valve in someone who had a torrential TR, and you'll see acute RV failure. So the Brenner paper was a great paper, and I actually had the privilege of writing an editorial with my colleague Jonathan Afalala about it. One of the issues that comes up, I have two questions here, is can we dichotomize at 0.406? Because patients are not ones or zeros. They're everything that we're measuring is really a continuum. And the second thing is you just mentioned the concept of RV reserve. Is there a role for stressing the RV preoperatively with dobutamine, with milrinone, to look at improvements in contractility?
That is such a great, I'm going to do the second question first. You know, none of the guidelines except the Japanese valvular heart disease guidelines even mentions stress testing for tricuspid regurgitation. But they do, and indeed there's a wealth of literature in the pulmonary hypertension cohorts, you know, of using stress testing to prognosticate. And I think you're right. I mean, I think maybe we should be going to stress testing and see how they do with the increase in afterload from the stress. You know, the blood pressure goes up, and you know, so it all gets transmitted back. And do they have enough RV reserve? I love that idea. We've not done it because probably because we're still getting these patients too late. And so they come in with massive amounts of ascites and edema and don't do too well on the treadmills. But I think as we're starting to move earlier and earlier, we may be able to then, you know, use stress testing to our advantage and really pinpoint the patients who we should take now to intervention. And your first question,
0.406, dichotomous cutoff.
Yeah, you know what, many of us use dichotomous cutoffs. I don't think that it's, as you say, a strict cutoff. And so the question is can we find that area, that gray zone? I mean, clearly, I think the case had phenomenal RV peak. I mean, I think it was over 6.6 or something. It was tremendous. And I would have really anticipated this patient would do just fine. But can we find where that gray zone is? But you are correct. It cannot be a single number. Right now, we're putting out those numbers, and for native valve disease, it's 0.35. For the thing that's you know, kind of nice is that we're pretty close to that for the transcatheter valve. So my guess is it's going to be somewhere around somewhere around 0.3 to maybe 0.5 or 0.45. But we are getting same numbers in different studies. And so I think there is something real to it.
That's great. I will now ask Karima about CMR and CT in structural interventions. Karima, what is their role when compared to echo? When can we liaise on CMR and CT?
So that's a great question. One of the things about echo, as we all know, is that the right ventricle is not really well seen. And sometimes we are not able to assess how big the right ventricle really is and so forth. So I think there's a role for MRI there because it is considered to be the gold standard in the assessment of the volumes and ejection fraction. So Sometimes we also use use MRI to assess tricuspid regurgitation, although less so. The other thing about using cross-sectional imaging, both CT and MRI, is that if you are not quite sure why the RV is dilated, so is there a shunt or is there some other reason why the RV is dilated, dysfunctional, MRI can help you with that.
Thanks. Question for Maurizio. We have a lot of imagers on this call. We don't have a lot of catheterizers here in terms of measuring hemodynamics. Is a right heart cath a sine qua non? Should we be going more with PAPI as opposed to non-invasive parameters in order to assess, should we be doing this for every patient in order to assess the potential outcomes or complications of these patients?
Yeah, actually, there are many centers who are not doing, which are not doing right heart catheterization on a standard basis. But in my opinion, since there is a lot of discrepancy between non-invasive and invasive evaluation of the pulmonary resistance and pulmonary pressure, I think it should be really part of the screening pathway to select the patient, even if we are still learning which patient could profit, which patient would benefit and which one not. But for sure, for example, if we have a patient with severe precapillary isolated pulmonary hypertension, we know that this patient is not going to profit, even if we abolish TR, and if acutely he can get home quite early, this is a patient that is not gonna profit most likely. And I would like just to make a comment on all the discussion that we have been doing. You said before, sometimes you should aim to imperfection. I think we should aim to select the patient that can tolerate perfection, like the case that Neil showed. Obviously, it was unexpected, and it was not always like this, that you can achieve trace with one single clip. But actually, the patient had afterload mismatch, but recovered, and the follow-up was great. So we should really identify patients where we can have zero TR, then we can discuss whether replacement is the same as repair. I don't think it's the same, because still it's not only matter of TR reduction. We are putting a big device with risk of thrombosis. We somehow impair the basis of the right ventricle. We can induce AV block, but still we really need to learn which patient could tolerate perfection and aim to perfection. That we are not always so good to achieve perfection, obviously, but I think it's wrong to be happy with some degree of reduction of TR just because we are not able to do better. This is my opinion.
Thanks, Maurizio. So that was a great philosophic statement. Before we close, does anybody else have any philosophic statement they want to make, just for the audience? Some words of wisdom on the panel?
I mean, we're just still learning so much, right? And it's just a funny valve where we've been starting to learn about pathophysiology after we have the devices. And so I think, we're just catching up with each other. We learn a lot more pathophysiology as we have more devices that do funny things, and then we have to figure out why. But I think we're getting there, and that's the beauty of it. With 3 randomized trials now out there against medical therapy, I'm just so excited. I think within the next couple years, we'll actually have a device approved in the U.S.
That's great. I really want to thank all the presenters, the panelists, on behalf of Julie Grapsa, the ACC Imaging Council, and the JACC case reports. I think one of the important things why I love case reports, and I've always loved case reports, is that it's through these individual cases, what I call the N of 1 experiment, that we really identify the issues that lead us both to find solutions and understand the physiology. Just like Becky said, we have the devices, now we're trying to figure out what to do with them. We see a complication and we work backwards in order to understand the physiology. So after today's Journal Club, I think a lot of us know a lot more about the tricuspid valve, how to image it, what we can do about it, and understand why, when things go bad, what we should be looking at. And for me, I always default back to my fundamental equation of cardiology. My 2 fundamental equations of cardiology. One is R is equal to L. We heard the stroke volumes are optically matched, despite the fact that one does a lot more work than the other. And the other one is V is equal to IR, pressure is flow times resistance. When the patient becomes hypotensive, is it a stroke volume problem or is it a resistance problem, and work through that way. So thank you again. Have a great afternoon, and thanks for joining us. This is recorded and will be available on the ACC Imaging Council website likely by next week. Thanks. Take care.
Great. Bye-bye.
Thank you. Bye-bye.